That is a piece of harm reduction too that says you learn best when we value you first. And I think that's the just this, for lack of a cliche different than this cliche, that's the secret sauce of the clinic. It's the notion that in that dynamic of all of our providers together, it's saying we value you, we want you here, we believe you can make a contribution to this world, and we want to help you meet whatever goals you have.
I want to empower all of the primary care physicians specifically that this medicine is doable. These patients are a joy to take care of when you build
Mm.
relationships with them. And we have a lot of power to reduce medical harm and stigma and engage them in their own care. At the end of the day, that's really all we are trying to do is help the community that we serve. And we have found a model that's been particularly effective in our building for our population. It may look different in your clinic, but I really want to empower primary care physicians that addiction medicine is something you can incorporate into your everyday practice. And it's very, very rewarding.
Dr. Seth Hunter, Chaplain Dustin Hite, thank you so much for joining us today on the Annals of Family Medicine podcast.
We are really excited to be here. Thank you for having us.
Yes, thank you.
Thank you. First, for our listeners, we have listeners that come from all different backgrounds. Very basic question, maybe for you, but maybe not for some of our listeners. What is a chaplain?
So that is a very, very broad question, in the sense that chaplaincy has been a part of various spaces in our culture and society for centuries, and in many respects. As it's understood sort of in my context, and that's what I'll speak to. In our context here at IU Health, chaplains and chaplaincy services come alongside and assist patients and staff as they engage in the various and variety of experiences they have as part of the healthcare system. And some of that is to assess and offer interventions for spiritual distress, emotional distress. Some of it is to connect related to mental distress as much as is possible in terms of our training, and then to offer appropriate referrals beyond that. But one of the broad things, and I think this is a question that might be helpful as we think about even the article that Dr. Hunter and I and others wrote together, is the notion that I see, at least I'm going to speak for myself, I see myself as a chaplain in this space, coming alongside patients, seeking to help them make meaning of the experiences that they're having. And so it's not the chaplain's job to prescribe how a patient should understand or experience what they're going through. It isn't our job to direct them to any sort of conclusions, but rather to listen, to offer questions and opportunities to think about resources they may already possess that will help them shape the meaning of the experiences that they're having, and or address the distress that they're going through. And so much of our job tends to be that in those spaces between lived experience and what medicine can do, how can we help patients connect with meaning in the middle of that? Sometimes that's religious, and at other times it's not. But it's truly just an effort to come alongside, walk alongside our patients as they are striving to figure out, what does whatever I'm going through mean for my life and for my experience of it, and what tools or resources do I already possess that can help me in that effort.
I think that beautifully summed up the role of what Dustin does for not only staff but for patients, and really creates this open environment to really find the resources that somebody already possesses, is what we call recovery capital, and use that to their advantage and help make meaning out of their post use or post addiction life and experience, oftentimes helping patients see a future for themselves that they don't have the focus yet to see. Dreaming and imagining a future for a patient and helping them reshape their worldview to incorporate that they didn't previously have.
Thank you. A phrase that makes several appearances in your publication, which is how patients make meaning of their experience, and that this was a central focus in this program. And Dustin, in your work with patients, could you elaborate a bit more on the meaning of that particular concept of how patients make meaning of their experience?
Yeah, I think in relationship to our Suboxone or Buprenorphine Clinic that Dr. Hunter and I are a part of together, I think one of the ways that we come alongside and try to do this with patients is that if you think about someone who is coming out of active use, or at least wants to have safer use, and is in the midst of kind of coming to terms even with the diagnosis of a substance use disorder. Sometimes patients get to us and they're not really ready to embrace that yet. And so part of the meaning making that can happen in that space between what our medical providers like Dr. Hunter provide and what chaplaincy can provide to them is wrestling with some of those deeper questions about what does this mean now going forward for me? Sometimes that's a social meaning making, like Dr. Hunter was alluding to with the idea of recovery capital, that for many of our patients, their social circles have centered around their use. And so now, how in the midst of your recovery do we help you find meaning and purpose in other social constructs and other social spaces and with other people? And how might you reconnect to past ones as well? And what does that look like? Many of our patients have trauma histories. And so some of the meaning making in the midst of that is getting to the place of even admitting that. I mean, I think that's a huge part of what I've seen Dr. Hunter be able to do, as well as what we in the chaplaincy space can do as we come alongside patients, is that's a hard thing. And maybe part of their use history has been a response to that trauma. And so part of the meaning comes and just is how can we name that reality? And then what do we do about that? And what can we provide as a clinic as a whole to you to help you address that? And I think for others, meaning is just simply dealing with things like shame and guilt. Like meaning making becomes, now what do I do with this? I did X, Y, or Z in my active use. I'm struggling with that. How do I integrate that into who I am going forward, knowing that that's the life I have lived? And how do I wrestle with that? And the guilt that often comes, and the stigma and the shame that often comes with that. And how do we process that in order to help you become a fuller person in your recovery that can integrate that into who you are, but realize that isn't all that you are. And I think that's also part of this meaning making experience. And I don't think it's just solely the role of the chaplain. I think it's the chaplain with the medical providers like Dr. Hunter that when those things come together, we're able to kind of holistically address many of those things.
It's very, very powerful. Thank you for sharing that.
I think from my lens, what Dustin has helped do in our clinic is really reinforce this idea and transition from medicine being a very clinical space to a very narrative space, and being able to help patients tell, understand, and interpret their own narrative experience while we use tools like Suboxone to help stabilize them chemically, medically, biologically, to really deal with some of these things like Dustin alluded to: trauma, shame, regret, those kinds of things. And then, in the midst of recovery, dealing with those, but also helping write a narrative moving forward. That just because these chapters have been written, what is the next part of your story and how does that look? And part of the coaching that we have incorporated into our clinic model really focuses on asking those kinds of questions for patients to consider and to wrestle with and grapple with as we walk through them in their recovery journey.
Thank you. Thank you. Let's jump into describing what the actual program was. If you could give us a bit of a history and how it came about, the idea to first bring chaplaincy into the clinic, and then if you could describe for us the program that you started in the Buprenorphine Clinic.
At IU Health, we are situated very uniquely in the intersection of a residency training program. Our clinic is housed within the IU Health Family Medicine program in downtown Indianapolis. And so we have the privilege of having residents alongside us in clinic learning about chronic pain, about substance use disorders. And so that's really where this clinic started, was meeting some training requirements for our resident learners. all of the credit for this clinic goes to my very good friend and colleague, Dr. Carol Dellinger, who started this in 2022, who's been very active in this space. And so she has another clinic that she's helped design called our Chronic Pain Assessment Clinic. And that clinic is a team-based model. And so it has an interprofessional workflow to it. So in that clinic, we have physicians, physical therapists. At one point, we had some dental professionals, occupational therapists. Dustin is in that space in the chaplaincy realm. And so we took this model and applied it to specifically opioid use disorder, and looking at through things in an interprofessional lens, trying to become a one-stop shop, if you will. And so this was started in 2022 as part of our training program and has really blossomed into some really beautiful experiences. Our goal with the clinic is to help treat opioid use disorder in patients in a non-stigmatizing, supportive way, and hopefully build trust within that patient population to help engage them in other parts of primary care is the end goal. I'm sure we'll talk about it in the future about, where do our patients go after they have reached stability, but that's kind of the pathway that goes. And so every visit, we have an intake initial kind of like get to know you visit where we take your whole history, kind of explain how things go. And some patients come to us already on buprenorphine. Some patients come to us in the throes of withdrawal. Some patients come to us in active use, and we meet them wherever they are on that day and come up with a treatment plan initially, and then see them back as needed. And so at every visit, they meet with the physician team, and that is required. And then they have the option to meet with other professions within our clinic. So they're offered to meet with Dustin at every visit. They're offered to meet with our social workers. Intermittently, we have a trained peer recovery coach who is in clinic that they have the option to meet with. But none of these things are mandated or required to receive treatment and care. They only have to meet with the physician. If that's where they are in their journey and that's who they want to talk to that day, great. We'll take care of them in the best way we know how, and then offer these supports and resources. We see people every week to every 3 months, depending on where they are in their recovery journey, and kind of adjust treatment plans as needed. And so I'll let Dustin kind of give his perspective on how that workflow looks real time.
Yeah, I think the thing I would add first in terms of the history of the clinic, and I want to highlight this particularly, is the notion that Dr. Dellinger is a key to this happening. And I think that partnership and her championing chaplaincy as part of the care that we can offer to our patients, not just in this clinic, but in our chronic pain clinic, in our clinic as a whole, has been why we've been able to do this. And her seeing the vision for why this could be valuable to our patients I stepped in, I started working, and this clinic had just started, and they invited me to come. That's how I got there. So it was something that was created before me. And had just, I think, met 1 month prior to me arriving. And then they invited me to come and be a part of that, Dr. Dellinger in particular. And in terms of workflow, one of the things that's on a week in, week out basis with the clinic that's important to highlight is that team-based approach between staff physicians or attending physicians, residents, myself, and any other disciplines who may be present. It's creating that comprehensive plan. From my perspective, there's no one discipline outside of the medical treatment these patients are provided, because I think regardless of if they say they don't want to see anyone else, our clinic is based on the value and the premise that they will still get their medication. And so everything else we can provide is just a means of saying, we believe in you and in your recovery, and we want to offer you resources if you want to use them. And so I think that's important to note, that the physicians could do this work. Dr. Dellinger and Dr. Hunter could do this work without me because of the stated goals of this clinic. And everything else we bring into that is just an opportunity to say, we want to give you all the tools possible to be successful with the goals that you have. And here's the folks that we think can help you in that. And that's sort of the approach we go into every time we huddle and meet about our patients is, what might this patient need today? What do we know about them? What conversations have we had in the past, and how can we help them take the next step in their recovery journey?
Thank you. I wanted to clarify something from earlier. So even if a patient says during the first appointment, no, thank you, I'm not interested, you still do offer it to them each time?
Yes.
Yes.
Have you found that there are some patients who, with time, kind of soften up to the idea and eventually say, you know what, maybe I will? Or is it kind of you could see the writing on the wall that once someone has said no, that's it?
I'll have to ask Dr. Hunter too to think. I can't think of a patient who's ever declined.
I can think of a few who initially did not want to meet with you. Most people say yes. I think the first time that we meet patients, there is still this sense of compliance that I'm
Mhm.
here, I need to do everything that the doctor says, because that is a traditional experience that our patients have at other treatment centers, is I need to do everything that's in this plan in order to get X, which is usually the Suboxone piece. I think Dustin can attest that sometimes the first couple of times that you meet somebody, they don't speak very much. There's not much to say. They're checking a box and said, yes, I did what the doctor wanted me to do. Over time, that trust is built, and there's some really enriching conversations that Dustin has been able to have with patients. On the flip side, in the few cases that patients don't want to meet with Dustin kind of right out of the gates, I tend to do a little bit of probing to figure out why and understand their perspective. Chaplaincy has weight behind it, both positive and negative, for different people. And so, if there is, well, I was really traumatized by my experience in the church and I have no interest of speaking with anybody with a religious background. I sometimes try to help reframe the role of Dustin that says, hey, I totally respect your experience, and I can guarantee you that you can look at Dustin as just a person who cares about you. And, I think that you'll find that he's a very different experience than anything that you've had in the way that he approaches the care that he gives to people. If you're more comfortable, I'm happy to sit in the room with you while you speak to him. If we have good rapport, those types of things. Over time, I think all of our patients have really engaged with the care that Dustin gives, either by a little bit of prodding and helpful support, but also by building trust, which I think is the cornerstone to any success that we've had with this population, is that we show up week in and week out, good, bad, and ugly, without judgment of what has happened. And that heals a lot of medical trauma that our patients have experienced. And I think that is why we have seen really pretty good retention of our patients and success in being able to transition them when appropriate back to primary care and opening doors to treating other medical problems that they have and not just focusing on their substance use, which is really important in helping them understand and create a new identity outside of their use, is that there are other parts to me and I can honor that and take care of that as well.
The thing that I would add is we do our level best to ensure that no patient feels that there are hoops that they must jump through to get their medication, including me. And I think that power understanding, that power dynamic becomes important for us to realize and be aware of in those moments, that they are there for one thing and one thing only, and that is this medication that is assisting them in their recovery. And any barrier we put in place to that only adds to stigma, only adds to struggles in their recovery. And also realizing, I think one of the sensitivities we've had to have is how much of recovery avenues have a moral framework. And it's not that people haven't found recovery in, for instance, 12-step pathways. But if you really pull back the layers of 12-step pathways, it's a moral framework that began it, and even a religious one at times. And whether we intentionally say it or it's passive, that moral framework can be detrimental to someone's recovery, depending on the person. And so the presence of a chaplain, I have to be sensitive to that, could add to that, leeriness, could add to that stigmatization that they've experienced in other programs, and navigating that and paying attention when it happens and allowing other providers to note it as well if they see it. I think is how we've been able to kind of create that trust and acknowledge that for many of our folks, recovery is hard enough, let alone adding on top of it, whether we mean to or not, a framework that may seemingly be passing judgment on them. And I think that's sort of just a fine line that we have to walk with every patient.
You've seen 48 unique patients, and as I understand, 12 of those patients only completed the initial visit, whereas 8 of the 48 went on to have several more appointments and ultimately met or exceeded the 12-month criterion for success in achieving sobriety. What happened to the other 28 patients?
They are still in the program. They're still coming to clinic every week. Some of them have had reoccurrence of use that we have walked through together. Some of them are weaning off of their Suboxone for one or another reasons. Some of them just want to keep seeing us, that they have met the criteria for success, where like, this is the place where I feel heard, I feel supported. I want to continue seeing this group of providers, even if I have another provider to transition me and continue my care after our buprenorphine clinic. And so that kind of middle group is they're still active patients in our clinic that we see on a regular basis.
So for those patients where recurrence of use is something that happens during their treatment course, from the chaplaincy perspective, how do you, Dustin, approach that when, you've been working with someone or maybe not, but now this is part of their story and their time in their clinic with you?
Well, I think in part, the first thing we do as a clinic whole, whether it's between Dr. Hunter, Dr. Dellinger, and the other providers who are there regularly versus our residents who come in and out, is normalizing the notion that recurrence of use is part of recovery. It's stating that from the beginning. We don't want you, if you have a recurrence of use, your response might be to feel guilt, shame, and want to hide that. We want you to come. And still come to the clinic. From the very beginning, they hear it from me. They hear it from Dr. Dellinger and Dr. Hunter. That is part of any recovery journey, is a recurrence of use. And what has become interesting is, as we think about that from the perspective of our patients, is, for instance, again, comparing to a 12-step model. In a 12-step model, you would start over in terms of how long you've been in recovery. And so you would be back at day one. In our clinic, as that has become normalized, it's interesting to listen to the stories of our patients who will have a recurrence of use, but they will still trace their recovery to their initial desire to change. And I think that's actually speaks to the strength of the clinic as a whole, is when patients start noticing that, not disengaging from the clinic when that happens, not coming, but being freely willing to share with us when they've had a recurrence. I mean, Dr. Hunter may have stories as well, but some of our toughest patients, that when we met them at the first time and we're like, man, I'm really worried about this person, have actually become some of the most open and honest with us about their journeys, and just will come right in and say, I had a recurrence. Here's what happened. And we talk about it, and we just normalize that as part of their journey. And every single time we hit the notion that there's still support here. How can we help you? What were the triggers that may have caused that to happen? I think they hear that from us, both my discipline and the medical side. Hey, let's think through, when you had that recurrence, what was going on? Were there certain triggers? How can we address those so that maybe if those come up again, you might have a different response if you want? But also noticing that our clinic as harm reduction has first and foremost that we want to value the person and we want to make sure they're alive. And if they disengage or if they stop coming because they've had a recurrence, then we can't help them do that. And the doctors cannot do their job if the patients don't come to the clinic. And I think that's sort of the framework. And it's hard at the beginning because, again, chaplaincy's association with religion, and then religion's understanding of addiction oftentimes as a moral and personal choice, which is still prevalent all over the place, at times can be a barrier if patients have a background in that. And so that becomes my responsibility to figure out how can I address that and also make this patient feel safe. And that's why we never push. If they push back against me or they're not ready to see me that day, okay, I'm here when you are, and you can access services at any time. And I think that's kind of a framework that we use in order to address that.
I'm sure you both know the rock singer Scott Weiland, Stone Temple Pilots. He wrote a memoir maybe about 12 or 13 years ago that I read that is kind of speaking to what you're saying. He goes through, yep, and it was another stint in rehab. Yep, it was another stint in rehab. And then he gets this point of, what if there was this idea of that this is just the way it is and that this is who I am. And maybe if there's that mind shift, acceptance doesn't have to be a resignation, but that it can actually help. And it was a very progressive idea for the time. And it's so refreshing to see more people like you that are doing this work. Along those lines, I did read in the publication that you did work with a harm reduction model. And for our listeners who, again, may not know what that term means, what it means in a medical or behavioral health or a clinical setting, and then expand upon what that might mean once you bring chaplaincy into the picture in a chaplaincy setting.
From a strict medical lens, harm reduction models are ways to provide care and create systems that reduce medical complications, or to use harm in the definition of harm reduction, to reduce harm to patients. What that means realistically is truly just meeting patients where they are, understanding what their goal is. There are patients that we take care of that they are not ready to be abstinent. They don't want to stop using drugs, but they don't want to die. And we embrace that with open arms in our clinic and say, great, I'm glad that's where you are. I'm glad you're here today. Let's start with primary objective. How do we keep you alive? For us, that's the use of Suboxone, which is shown to reduce overdose by 50%. And then tell me about your use pattern. Are you injecting drugs? Tell me about that. Great. Do you have alcohol swabs? Let me get you some of those so you can clean your skin. Do you use the same needle all day? Do you have enough needles? How can we get you clean needles? Is there an exchange program next to you? Can you get these at the pharmacy? How do we make your use safer? Who are you using with? Do you have naloxone with you? Do you have somebody who can use it? Are you using it in a safe place? Is there heat? Those types of things are questions that we ask and we think about, and how do we help support you today so that when you are ready for abstinence, which as a physician is my goal, I want to see people achieve abstinence and have that in their recovery and sustain that for their overall health and well-being. But if you're not there yet, great, I'm here right beside you. I'm going to be there until you are ready, and then we're going to take that next step together. So truly harm reduction is just thinking about how to make your life safer with the choices that you're making, and any role that I can play in that, whether that is psychological safety, physical safety, I'm willing and ready. Our clinic is willing and ready to help put those supports in place for patients.
I think I would add, from my perspective, harm reduction looks like the notion that at the end of the day, we know how we as human beings take any positive step forward. And it is hardly ever done with sustainability through punitive action. It is almost always through openness, through love and care, through believing that you can make your own choices. And yet, we've adopted models around substance use and substance use disorder that actually work in frameworks that are directly in opposition to that, and wonder why we don't get results. And so from my perspective, harm reduction looks like the notion of just saying, I believe that you are still worth making choices that you want to make in your life, that you still have agency, that you still have worth, that you still have opportunities regardless of your story and regardless of your past use or your continued use, that you still have gifts and things that you can offer to this world. And I think that is a piece of harm reduction too, that says you learn best when we value you first. For lack of a cliche different than this cliche, that's the secret sauce of the clinic. Like, it's the notion that in that dynamic of all of our providers together, it's saying, we value you, we want you here, we believe you can make a contribution to this world, and we want to help you meet whatever goals you have. And we're not going to punish you if you mess up. We're going to invite you in to stay with us and walk with us, and we're going to walk with you through that.
Thank you. So to go back a little bit to the patients in your clinic directly that you spoke about in your publication, was there a difference in how the two groups that you specifically cited, the 12 who only completed the initial visit versus the 8, or even, the patients that you're continuing to see who are doing this longitudinally, was there a difference in how they utilize chaplaincy as an aspect of their treatment and their treatment plan?
That's an interesting question. I don't know that I had thought about it from that perspective. I think just what I can think of off the top of my head, and Dr. Hunter, please, interject or add to this as you see fit. for those patients that were not long-term engaged with our clinic, I think in each of their stories, there's a notion of there was so much going on, and it became a barrier to just engaging the clinic as a whole, whether that's a transportation barrier, whether that's a financial barrier in the sense that they're quote unquote couch surfing and they're not in the same place for very like there. I think that there are just a lot of factors in each of those individual stories that it's hard to pick that there's just one or two factors as to why they did not maintain engagement with our clinic. But I think in all of them, what I would say is, from my perspective, they were each of them facing hurdles to their recovery, to their accessing of care. There was multifactorial things going on in their life. It was just a lot. And any one of those factors, I think, could be named as a barrier to them actually engaging long term.
Yeah, I would agree with that. I think the effectiveness of chaplaincy in our clinic is one that comes from the benefit of longitudinal relationship. And the patients who we've been able to transition back to their PCP have a more longitudinal relationship with Dustin and the care team. And I think that is really where the benefit came from. In the group of patients who had an initial intake appointment, obviously that longitudinal relationship is not there. That trust was not built. And I agree with Dustin that in most of the cases, there were outside factors that were very large barriers to engagement with the clinic. Another one that has not been talked about has been repeat incarceration. And so patients would be on parole and establish in our clinic, and then for a variety of reasons, we're sentenced back to incarceration for a period of time. And so we're lost to follow up. Another kind of barrier that we have noticed in this population is, again, the transient nature of many of their living environments, whether that is, I'm not in the same place every night, or I went to go live with a family member on a farm 2 hours from where the clinic is to be in a different environment than where I currently am. Of the 12 that only had their initial intake appointment, I can think of about 2/3 that had those kinds of circumstances where they either left the area, did not have the physical means to coordinate transportation on a reliable basis to get to clinic, or had involvement with the criminal justice system and were required to go back to a period of incarceration for a variety of reasons.
Have you had people come back after their incarceration?
We have,
Wow.
yeah.
Wow.
It's very distressing actually for us as a clinic that these patients will disappear, and we don't know what happened. And then 9 months later, they will show back up on the schedule, and we'll say, "Hey, what's been going on?" And they say, "Well, I've been in jail for the last 9 months." You're like, "Okay, cool. Let's talk about that experience. What happened? Where are we at?"
There should be some sort of pipeline information system where folks like you who are that directly involved should know when those things happen, or there should be some sort of central EHR kind of thing for notification for that kind of thing. But maybe it's just my naive wishful thinking. But that's very powerful that they get out. I'm going back to IU and I'm going back to this group. Once people are transitioned back to their PCPs, do they still have the option of speaking with you, Dustin, and continuing a relationship with you?
Yes, one of two things can happen. One, I serve in the broader clinic as well, so I'm not just a part of the Buprenorphine Clinic. I serve the clinic as a whole. So there's opportunities at any time to engage if a patient desires. I also have the opportunity to provide them with my contact info, so I am allowed to do telephonic support. It's less ideal, but it's an avenue to reaching out to me. And so we provide that to our patients as well, that there's an opportunity to reach out to me at this number, realizing that obviously it's not 24/7. And if you're in distress, we provide resources for what to do in those moments. But patients can still utilize those means of communication.
If it's okay for me to ask, if it's not too intrusive, if you come from a specific religious background and what it was like to navigate support for patients who come from different belief systems and having that balance.
Yeah, so I do come from a particular Christian tradition. We as chaplains within the healthcare space in the United States are required to have what's called an endorsement from a particular body. Usually that's a religious body, but it doesn't always have to be. We also are required to be board certified and adhere to a code of ethics that prevents and completely disallows the notion of like proselytizing. It doesn't mean we can't engage patients if the patient desires that, but it is not our role or our desire to come in and kind of impose religion on anyone. And I think that's the cultural understanding of a chaplain, because there's still remnants of that. And chaplaincy did begin in spaces that were very religiously and dogmatically oriented. But in the United States healthcare system, chaplains and in the government are required to adhere to certain things. And one of those is to be non-sectarian, to be able to engage with any patient at any time. For instance, I tell the story that at one point I was doing an on-duty shift in the ED here at our large Trauma One center. A patient asked me for a satanic Bible. If I had had a satanic Bible, I would have provided that to that person. I mean, we don't traditionally stock those because we don't often get asked that. But if I had had it, I would have provided it to that patient as an act of service honoring their faith tradition or their belief and orienting system. And I think that is the piece where I come to this and say, and Dr. Hunter has heard me say this multiple times, I can only speak for who I am as a chaplain and how I understand chaplaincy, because I do believe it's a practice. It's much like medicine. While there's an underlying foundation, how we live that out is often unique to the person. And so I come from a tradition that honors the spiritual journey of each individual and understands the approach that I take is to say that religion is just one way to be spiritual. It's not the only way. And I think that's an important dynamic to realize when we think about chaplaincy and spiritual distress. Spiritual distress for me is a very broad term. It can mean that someone is wrestling with, I had these beliefs, my current human experience doesn't line up with these beliefs. What do I do? Because I'm in crisis now. It can mean that. But oftentimes it's much broader than that, because spirituality is bigger than just religion. And so I think that's the approach I bring to this. And just noting that for any number of our patients, even if they are religious, that is just one piece of who they are. It informs how they interpret their experience, but it isn't the only lens. And so I think part of our role as chaplains too is to, yes, pay attention to that, but also to assess and note that I could be bringing any number of lenses to look at this experience I'm having. And I, as a chaplain, need to pay attention to that, and also to pay attention when cultural understandings are available. So I try to pay attention to body language when I get introduced. Like if someone shudders, I'm going to ask, hey, I noticed that when I was introduced as the chaplain, you had a little, I just noticed something. You want to tell me about that? Like, is there something that brings up for you? And we'll talk about it, and we'll just name the reality of what that response is, and hopefully offer information about how this role is a bit different than maybe what they were assuming. But more often than not, I will tell you that the most used cultural understanding of chaplaincy is that I'm there to deliver bad news. That is more often than not. It's not he's here to convert me. That's less what I experience. It's more, are you here to give me bad news? And that's more the cultural understanding that patients have. So I don't know if that answered your question. And Dr. Hunter, if you want to add to that, you can as well.
What I think may be unfamiliar to the listeners or the audience is the use of chaplaincy in the outpatient space. Traditionally in the House of Medicine, we think of chaplaincy in the inpatient model, where oftentimes they are brought in for very distressing situations, loss of loved ones, traumatic events, those types of things. Chaplaincy in the primary care model is very much more of a relational experience to help support. What we have found is a lot of social poverty and isolation. It is another member of the care team that walks into a room, even if the patient, if they have substance use disorder or don't, that says, hey, you matter in this building. We care about you. We care about your circle of people who care about you. And I'm here to walk along and help process your walk through a chronic disease with diabetes or substance use disorder or hypertension, your stroke that now you are limited in playing with your grandkids. Let's talk about those things. And so chaplaincy in the primary care sphere is really shifting the role or expectations of what chaplains do. It is more of a shepherding mentality, if you want to use religious language, than I'm here in a moment of crisis. And I think that's a very new and different model, one that I have not seen outside of the IU Health practice system. And so one that we are hoping is expanding across the country.
Has having Dustin present changed in any way, Dr. Hunter, how you approach anything in your work? Has it
I think
shifted your
Dustin has
outcomes?
been transformative in the way that I practice medicine. The journey to become a physician is long and arduous and is started with incredible altruism and good intents. And through training is narrowed down to a lens of problem solving, science, diagnosis, treatment, data, and numbers. When I was an undergraduate, I have a minor in what's called health medicine and human values, which looks at the intersection between patient experience, cultural understanding, and how that interfaces with the medical community. Dustin has reminded me of the power of narrative in medicine, the power of listening to patient stories and building longitudinal relationships to create goals together. He has helped remind myself and has helped teach our residents that there is more as a primary care physician to treating the person than understanding their disease process. And oftentimes the disease process is the easy part. To really care for another human being is to understand their story and create space for them to tell their story and how they are interpreting or living with the diseases that you know about. How do they understand their disease process? I think Dustin has been transformative in the language and the conversations that we have with patients to help get them from where they are to where they want to be, or in a place that is hopefully preventing bad outcomes from happening in a preventative lens. And so he has been a breath of fresh air to remind me of the humanity in medicine, and that even though he is an extra support, I also have the tools to have those kinds of conversations and relationships with patients that we often rely on him to help with. And so that has just been, he's been a really, really huge joy, one of the best parts of my job in the last few years.
Well, I don't know what to say to that, Doctor. But I do want to add in tandem with this that Dr. Hunter and Dr. Dellinger have been partners with me in helping me understand the medical side of what our patients are going through. And I think that's the unique beauty too of the clinic that we have is they have to teach residents at times as they're serving our patients in the Buprenorphine Clinic, and I get to listen. And I didn't go to medical school, and I didn't know the first thing about dopamine and opioid receptors and anything else about how patients experience medically these substances and what happens when they're withdrawing and things like that. And that has been invaluable. They have not treated me as a side discipline. They have allowed me to enter into the education they are providing residents and ask questions and learn alongside. And I think that has been invaluable as well in how I can enter into the journey of each patient. Just that little bit of knowledge of understanding what they may be experiencing physiologically and what there is happening in their brains and how recovery impacts that and the medication impacts that. It's been a piece that I don't know that if I had that, didn't have that, I'm not sure that I could have sustained in this work as well, or had the same viewpoint of what patients are going through.
It sounds like Dustin is keeping that spirit alive for the residents. Residency is definitely a time when that foundation is perhaps at its shakiest. And it sounds like, Dustin, you're really upholding what a lot of us got into medicine for in the first place, and kind of reminding, the residents who are fortunate enough to work with you and be in your presence of why they're here in the first place. And the rest of us should only be so lucky to have someone like you at our residencies. Your training, Dustin, the background in recovery coaching, which you did talk about at length during our conversation so far, but the specific part of your training in non-anxious listening that is mentioned in the publication. Could you tell us more about what that is, and if perhaps there's any, because that was a new phrase for me. I don't know if there are other publications out there about it that you might be able to recommend, or that you referenced as you were moving forward with putting together this research project or the clinic. If you could tell us anything you can about it.
Yeah. I appreciate you bringing that out, because I think the struggle is sometimes we chaplains use language and labels that aren't immediately accessible to everyone else. Dr. Hunter knows that one of my biggest soapboxes is that our chart notes reflect that. Like, they're good for chaplains, but they're not for anyone else. And I think that's an utter waste of our time if that's how we're writing chart notes. But non-anxious listening or non-anxious attending, it's not a label for a particular, like, you can go and get this training. What I mean by that, and what we mean in our article, is the notion that so much of our listening culturally, in our personal lives, in anything we do, we're listening to respond, right? Yeah, I'm just waiting so I can enter into the conversation. And I've already been thinking about what I'm going to say in response to what you're saying to me. And part of what is really hammered home in our chaplaincy education is the notion that to truly enter into the experience of the patient, one, it isn't about you. It isn't about centering my experience. You're not going to go away from this knowing a bunch about me, because if you do, that means I made it about me. It's about you. And non-anxious listening or non-anxious attending is the ability to remove that need to respond and to be okay with silence. And I tell people, it's a learned skill, because I was not good at it. When I did my first interview for my first clinical educational block for chaplaincy, the interviewers had to tell me to stop talking, that I had answered their question, I was talking too much. And I'm like, oh no, this is terrible. I'm not going to get into this program because I didn't do well. And I think anybody can develop that ability. And I will lift up the times I've gone in with Dr. Hunter. I believe he is able to do this. It's to listen intently. It's to put the focus on the person in front of you. Eventually, you may need to put things in an EMR or in your chart note, but you don't have to do that in the moment. You can literally, as a chaplain, I will never do anything other than sit there in the moment and listen. There's no notes I'm making. There's nothing else. And I think those are just skills and things we pay attention to in our everyday conversations. How do we interact with other people? And also just being okay with silence, letting that sit for a moment, because in the silence, the person is able to really reflect on what they're saying. And it may be, if you rush in too quickly, you miss that and you're not able to get that. And so it's not a training in the sense that there's a seminar you can go take. I think it's realizing that much of our human communication is not non-anxious listening. It is very much anxiety induced. It's what I need to be ready to say, how I can prove them wrong, how I can do this or that. And in the chaplaincy space, and even in the best that I see in the primary care space, I'm going to honor your experience. I don't need to know whether it's true or not. It's true to you. You're sharing it with me. So I'm just going to listen. And I'm going to ask questions. I'm going to have a curiosity about your experience and not interjecting my experience into yours. And one of the chaplains I work with, he has a great analogy that we can either be storytellers, we can be story stealers, or we can be story catchers. And as chaplaincy in its best space, but also our physicians, when they're at their best, they are catching the story of the patient. They are holding it. They're not trying to tell their own story. They're not trying to steal the story that's being told. They are catching the story that's being shared. And I think that's what I mean by non-anxious listening. And I think that's where we get our patients really, truly able to share with not just me, but with our physicians as well, because we hold their story as they share it. Hopefully that answered what you were hoping for.
Did. Thank you.
Yeah, to put it less eloquently, I think about non-anxious listening as listening to understand and not listening to respond. And I think this is a powerful thing for the residents that we teach, is that oftentimes patients are coming to you as the physician for answers. And so we are trained to respond. We need to know the answer. Medicine is not that straightforward, but the answer is in the patient's story. And so if you approach interviews and patient encounters with an intent to listen to understand, the answer will be in there. And once you understand, then you can respond. And so there is information that you need to get in an interview, but the patient will tell you what's wrong. The patient will tell you exactly what you need to know if you are listening to understand their story. And that is a skill that is developed over a lifetime. I think it is something that I still am working on and finding the balance of how do I listen within a 20-minute visit, but also understanding that the response doesn't have to be immediate, that it's okay to say, wow, that was a really powerful story. I really appreciate you sharing that with me. I'm going to need some time to digest after our visit. Is it okay if I give you a call with an updated plan once I kind of figure out what's going on? That there's an ability to remove the response from the human interaction. And so much in the care that we do, whether it's chronic pain, whether it's chronic illness or substance use disorder or any of that, the therapeutic relationship is therapeutic. And most patients really, really just want to be heard. And if you take the time to hear them, the answers will come. And if I need to bring you back to talk about those answers, great. I gave you space to tell your story and to listen without judgment, without feeling the need to respond and have the answers for you. And so that's how I kind of think about non-anxious listening and try to convey that to the residents that we're teaching in clinic, is that that human interaction is probably the most sacred thing that we do, and we need to allow space for that. And if you allow space for that, you'll be surprised how much easier the medicine gets because you will know so much more about what will work for a patient.
Is there anything in closing that we haven't touched upon that you want to add?
The message that I would really want to convey to the listeners is that this is one model for providing primary care for patients who have substance use disorder. If you don't have all of these pieces, that shouldn't stop you from providing evidence-based, compassionate care to patients with substance use disorders. I had a very good mentor in residency who told me, if you don't think that you are taking care of patients who have substance use disorders, you're not looking for them.
Mm-hmm.
And I want to empower all of the primary care physicians specifically that this medicine is doable. These patients are a joy to take care of when you build relationships with them. And we have a lot of power to reduce medical harm and stigma and engage them in their own care. And so I hope that it doesn't become too complicated for people. That yes, this is one model, but there are many others. And the first step to doing it is to just start. And there is a great community of addiction medicine physicians out there who want to help support you as a primary care physician and meet the needs of your community and listen to the stories that they tell, and then find the resources to meet those needs. At the end of the day, that's really all we are trying to do, is help the community that we serve. And we have found a model that's been particularly effective in our building for our population. It may look different in your clinic, but I really want to empower primary care physicians that addiction medicine is something you can incorporate into your everyday practice. And it's very, very rewarding.
And I think that what I would add to this, I came to chaplaincy work through first responder chaplaincy. And in 2020 and 2021, I responded to so many calls of deaths by overdose. And that wasn't necessarily the surprising part. The surprising part to me was how many of those people had just come out of rehab, had just come out of required treatment, et cetera. Those calls were across the socioeconomic spectrum, like they were everywhere. And what that revealed to me was the notion that it isn't just about the substance itself. There is something going on in the lives of folks that we're just not paying attention to. And we love to describe those as deaths of despair. And I don't know that I love that label because it puts all the ownership on the person who has died and not on the society around them that has failed them. And I think one of the beautiful things about our clinic too is the notion that we have an opportunity to say we're a part of giving you whatever tools for however long you're with us that we can. And recovery supports in the community, for listeners of this, it doesn't take someone like me to give those to a Dr. Hunter. It's just knowing what they are in your community, knowing the models of pathways that there are in recovery, that they are different. There are different models, and knowing the ins and outs and the goods and the bads of them so that you can give them to the patient in the moment that they need them. And realizing that neither Dr. Hunter, Dr. Dellinger, myself, we cannot save or be the savior of anyone. What we can do is be the person who is there, acknowledging their humanity, championing their goals, and giving them resources while they are with us. And then understanding that for however long that journey is, we have honored our relationship to them. And I think that can be done by a chaplain, that can be done by a physician, it can be done by a peer recovery coach, a social worker. It's coming to the place of realizing that the person that's in front of you with this substance use disorder doesn't understand themselves solely to be defined by that use disorder, that they are a friend, they are a loved one, they are a son, they are a daughter, they are a father, a mother, on down the line. And being able to see not just the use disorder, but that too, that matters to them. And I think in our clinic, what I've been able to see is how physicians are doing that too. And I tell the residents who do it well, man, if you carry that into your medical career, there wouldn't need to be people like me. If that's what patients experience with you, if I see it, I call that out. That's what you need to take with you when you go into whatever is next for you, because that's what patients need. And I think that's what we've experienced. That's my experience with Dr. Hunter and Dr. Dellinger. And I think it's the reason why the patients who have journeyed with us have found value and support in our clinic.
Thank you both for sharing with us your expertise, your hearts, your souls. You brought your full selves to this interview, and we could not be any more appreciative. And keep up the good work.
Thank you for the opportunity to share.
Thanks for having us, Sherri.
Of course.